let's take a look at the clinical systems. We're just about to wind up, and you can ask your questions. But I want you to think about, because everybody's fighting so hard. You know, we're trying so hard to manage pain, and we have residents that just keep telling us that it's a 9 or a 10. But I just want you to go back and think about some things, too. Good old pain assessment. You know, all residents who should be screened for pain every day, on admission and every day. And screening, I don't mean some kind of a formal screening, because sometimes we're just observing and we notice things that are different. If we think the person has pain, we need to do a comprehensive workup of some kind. This is all part of FTAG 309. Those are our marching orders. We need to get a history. We need to have a physical exam of some kind and a measurement of your pain if we possibly can. We need to look at your cultural background, because sometimes stoic is a part of, being stoic is a part of somebody's background. And we need to know the etiology of pain, because we treat pain differently. Need to know the difference between acute pain and chronic pain. We treat those differently. Acute pain is something that recently happened. It's an event like a surgery or an accident of some kind or a fracture. Chronic pain is something that gets worse over time. It can persist for a lot of months. It can be around for years, like arthritis. Even cancer can be chronic. Neuropathy from diabetes or from chemotherapy. We need to understand the source of the pain, the etiology, because it's going to drive our treatment plan. We treat neuropathic pain different than inflammatory pain, different than visceral pain, and different than musculoskeletal. Not all pain is treated with narcotics. So you don't always have to jump right to the narcotic. It may not be appropriate. Many people who have neuropathic pain, narcotics don't help that at all. Some people have more than one comorbidity, and so they may have different kinds of pain. You still have to want to tackle each one of those differently. Not one solution is going to cure all. We want the resident to describe that pain in that comprehensive assessment. This is not part of the MDS. It's not part of the interview. It's part of our nursing assessment. We want to know if it's aching, throbbing, stabbing. I don't know how that, I didn't even touch that. Aching, throbbing, or stabbing. And we want to know how often and what's the intensity of it. That comes from the actual interview. We want to know, is it always there? Does it come and go? What kinds of things make it better? What makes it worse? You know, if you've ever been in ER, they ask those questions right there. That's part of their pain assessment. So now you're asking yourself, I gotta figure out why my numbers are high. And I'm going to give you some things that are on the slide and even possibly off the slide. I want to be able to see this better. So short stay, keep in mind that for the long stay, those base assessments are excluded. You get an opportunity to really manage that pain, and short stay, you don't. These are your Medicare people. They're coming to you sicker than everybody else, and they have a very frequent schedule of assessments. So we're always looking, we always have one that's most recent, and if you're not seeing change, I want to put to you to assess that pain on admission and make sure if you need something long-acting, because a lot of times people just come in with PRNs. Make sure if it's long-acting, to get something long-acting and maybe help that. Also think about those non-pharmacological and think out of the box and see what we can do to help with that. Also, the frequency of those Medicare assessments. The long stays, keep in mind there's a covariate. If you have a lot of cognitively impaired residents, it may be going up out of your control a little bit. So that's one thing. And go ahead and try and medicate maybe some of those who are not interviewable and see if that makes a difference. If you happen to see a behavior or agitation, you don't know if it's pain, but you don't know if it's not until you try. And if it doesn't work, then you know that perhaps it wasn't that. And we're doing less frequent assessments on those. Now, with that said, I'm going to go back to that for a second. With that said, on a long-stay resident, since these are mostly OBRA assessments that we're grabbing these, if you're able to get a resident pain-free and not due for another quarterly, go ahead. If your state allows you to do early quarterlies, go ahead and do another quarterly and capture that. There's no reason to not capture that better level of care and allow that person to fall off of your quality measure. I think that's a celebration. I think we deserve that. Interventions, they're just not always narcotics. Neuropathics, we treat with anticonvulsants, but you know, like Lyrica. But you know what? There are some topical cocktails out there that are very effective on neuropathic pain. There's one called capsaicin, and I actually think it has cayenne pepper in it, so it kind of burns on the skin, but people really love that. They get some kind of, almost like that deep heat feeling. So consider some of those others. Consider adding meds. That's part of good pain management. There are different meds that you can add. You can add acetaminophen to something that already has acetaminophen in it, as long as you're watching that ceiling dose. And you can add things like Elavil, the TCAs. Elavil is great as a pain added pain med, except in the elderly, because it does cause urinary retention really bad in the elderly. So they're just some thoughts. It's great to add with for neuropathic pain. Neurologists do it all the time. Don't forget about those non-pharmacological interventions. Sometimes we just need to get someone moving, like degenerative joint disease or arthritis, because the more still they are, the more they hurt. Hot packs, massage, and many, many more. I love Looney Tunes. I think they're some of the best cartoons out there, so I went out and found all of my favorite Looney Tune characters and got their game faces. You need to put your game face on going forward here. You need to keep analyzing your outcomes. Don't stop doing that. If you find yourself going resident by resident and saying, nope, it's high because of this, it's high because of this, you're missing the picture. You need to look at the objectively and take yourself out of it, look at the whole outcome, and consider hypothesizing why it could be off. Are all my people only on PRNs? And everybody says, no, they're not, and then I'll go through that resident listing and I'll go through and look at the MARS, and sure enough, they got all PRNs. And are we giving them? So it's interesting to go resident by resident, but I encourage you to stay on the outside first and start that way.